Now we shift, because of the multiple venous interventions done nowadays, we all appreciated Dr. Mohamed elmaadawey to speak about venous interventions, pillars for positive outcome. Dr. Mohamed elmaadawey is a well-known professor in Cairo University, and he is doing a lot of cases with venous interventions.
Good afternoon, my dear colleague, my chairman. Our talk today will be focused on the post-thrombotic syndrome. Before we start, clear evidence-based recommendations does not exist for which type of the management. As we know that the most classical management is the compression therapy, against which all the other modalities of treatment like the intravascular treatment and the venous bypass or the hybrid techniques are compared. For all invasive treatment, recommendations from the European Vascular Society, American Heart Association, Society of Vascular Surgery are no better than 2B and the class of evidence B and C. Recently, from the European guidelines and American guidelines, recommend endovenous management for severe post-thrombotic syndrome. And these recommendations were published in 2015. And this is the printout of these recommendations, and it reads, level of evidence for intervention in post-thrombotic syndrome is low. Class of recommendation is no better than 2A, which means should be considered. Since the advent of the dedicated stents for the veins, only 4 large studies involving dedicated venous stents were available. And also there is an insistent need for large comparative studies on the performance and the benefit of these venous stents to be recently published. The post-thrombotic syndrome is a benign disorder. It is not life-threatening. It is not limb-threatening disease. So any results, any management like the venous bypass, which entails high risk of intervention, is unacceptable. Like this is a classical technique of the Palmer technique. Similarly, the hybrid technique are bogged down in details, and they are costly and requires special concerns. In such hybrid technique, an endophlebectomy is performed through common femoral vein cut down in order to allow flow of the blood to the profunda femoris vein, followed by endovenous management of the iliofemoral obstruction, and patch is performed, and the surgery is complemented by AV graft from the common femoral artery and the common femoral vein using a BTFE ringed graft. This is to be later on closed either by endovascular management or by revisiting the same site surgically. Before embarking on the endovenous management of the post-thrombotic syndrome, the extension of the disease and the underlying pathology, notably the thrombophilia and the associated comorbidities like the cardiopulmonary disorders and the obesity must be considered because they give a negative feedback on the long-term success. Compression has its well-entrenched effect in the management of the post-thrombotic syndrome and should be commenced and continued uninterrupted after endovenous management. Also, a stringent follow-up is inexorable because you might have a stent occlusion long after it has been occluded and when it is too late to intervene with that patient. Here we start with the intravenous technique for the BDS. The anesthesia, usually we prefer the anesthesia to be general anesthesia because of the necessity for the use of multiple accesses removed from each other. And in addition, the dilatations of the venous segment calls or recruits more nerve endings than it does when you dilate an artery, and this is inside a very intolerable pain. The supine position is convenient and it can serve the jugular and the popliteal axis as well. Multiple axes are preferred because it is better to have an axis even if you are not going to use it before you need an axis after the patient is fully anticoagulated. And also it is better for the crossing, as we will see, and also it can serve as a contrast-free roadmap in order to gain your pathway through the obstruction, and it allows, as we will see, the through and through wire. We came from above, and there is a complete obstructions of the left innominate vein, and we couldn't cross this lesion when we come from below, but alternatively, when we tried it from above, the crossing was, as you see, successful. Then after crossing the lesion, the wire went into the azygous vein, and this must be considered during your journey because inflation here or any passage of a large an instrument there would lead to exsanguinating hemorrhage. After we manipulated our wire, we could manage to go to the inferior vena cava, and after that we managed to pass the wire through the femoral axis. Now you have two ends of the wire, one coming out from the femoral axis and the other from above, and you can introduce your instrument from above or from below according to your destination, and also it allows you to have a good pushability if it is required. The engagement is easy if you are going to perform exploiting the anatomical landmark and respecting the anatomical variations and also tolerating the extensive collaterals. Here, the first glimpse, you might think that the wire is going out of the iliac vein and you had perforation, but careful scrutiny of that reveal a bud and the absence of the extravasation of the dye. You are inside of the ascending lumbar vein. This is a textbook picture of the ascending lumbar vein occupying the same positions as of our wire. Also, you might get here instead of going through the innominate vein as you want, but after careful manipulations, you can get through this occluded left innominate vein. Also, you might get from the left, and you will find yourself on the right, coming through the jugular arch, which communicates the anterior jugular vein on both sides at that area. Unfortunately, we couldn't succeed with this patient. Here, again, the wire is inside of the azygous vein. On the picture on the left, you might think that you are in the correct track, but after you change the projection, which you should do in every case, you will find that you are away from the desired track. If you balloon this segment, you might lead to exsanguinating hemorrhage. Here we came from the left, and we passed the wire. The wire emerged there through what's called the substernal anastomosis, connecting both the internal mammary veins with each other. This is textbook picture to what we had already on table. Unfortunately, we couldn't succeed with that patient. ممكن دقيقة زيادة دكتور هشام، ممكن دقيقة زيادة بعد. Astinotic lesions are easiest to cross. Acute thrombosis is easier than to cross chronic obstruction. of a vein segment which is laden with a trabeculae, and it is as well fibrosed. The balloon angioplasty, larger diameter, and the high pressure balloon are to be used. The double balloon technique sometimes can help you if you go through a recalcitrant stenosis, or to compensate for the unavailability of a large reference diameter balloon. During deploying the stent, you should come from the normal to the normal. And the encroachment over the contralateral common eye leg vein, which was contraindicated at the time, is now relaxed in favor of covering the whole segment. This is, as you see, from normal to normal, and this is the free flow of the dye. Check angiogram should be performed after each step. Fortunately, the incidence of contrast-induced nephropathy is surprisingly low when you inject the same amount of the contrast material inside of the vein rather than inside of the artery. Thank you.